Good morning, everyone. Today I will be speaking on the role of chemotherapy in patients with small cell lung cancer with poor performance status. So staging, as it been previously discussed, limited stage and extensive stage. Survival for limited stage disease, median survival is 16 to 24 months. For extensive stage, it is 6 to 12 months, and without treatment, survival is 2 to 4 months. So coming to NCCN guidelines. So in patients with poor PS, that is PS3 or PS4, NCCN guidelines state administering systemic therapy if that poor PS is due to disease itself. And if poor PS is not due to disease, then individualization of treatment, including supportive care, is advised. Same is the case in extensive stage disease and superior vena cava syndrome. So PS3 or PS4 is not an uncommon presentation in small cell lung cancer. All the landmark trials that have established the role of chemotherapy, they were conducted in patients with good PS. There are practically no studies that systematically evaluated the risk-benefit ratio of chemotherapy in SCLC patients with poor PS. So this was a observational study from TMH, which evaluated the role of chemotherapy in patients with small cell lung cancer and poor PS. So this included patients of small cell lung cancer with PS3 or PS4. This was an observational study. Patients were initially evaluated in a multidisciplinary clinic, and the treatment was decided by the treating team. Outcomes measured were improvement in disease attributable symptoms, response rates, overall survival, and toxicities. The study was conducted from 2010 to 2019. So total 258 patients were assessed for eligibility, and 234 patients were enrolled into the study. Out of 234 patients, 185 were decided to go with chemotherapy, either in reduced doses or standard dose, and 49 patients, that was around 20% of the patients, were selected for best supportive care only. Out of the 185 patients who were selected for chemotherapy, 154 patients were initially given reduced doses or attenuated doses of chemotherapy, and only 31 patients could receive full dose chemotherapy. And out of the 154 patients, later on full dose chemotherapy were given to 74 patients, and the rest of the patients were either continued on attenuated dose of chemotherapy, or they were stopped chemotherapy due to their poor PS or comorbidities. So the regimens which were used in reduced doses chemotherapy, either single agent chemotherapy like single agent carboplatin AUC2, or flat dose carboplatin, or flat dose cisplatin, or low dose cisplatin. In low dose or attenuated dose combination chemotherapy, regimens used were cisplatin etoposide or carboplatin etoposide. So coming to the overall survival, in this study, patients of SCLC with PS3 or PS4 status were managed with, those who were managed with best supportive care, median OS was 1 month only, as compared to 6 months in patients those who received any dose of chemotherapy. So this was seen across most of the subgroups. And response rates to first-line chemotherapy in patients with SCLC and poor PS was 77%, and median OS was 6 months. So in the literature, the expected response rates to systemic chemotherapy in SCLC ranges from 70 to 90%, and expected median OS in extensive stage is 8 to 13 months. So our patient cohort had shorter OS than described in the literature, again reiterating to the fact that poor PS is a powerful prognostic factor in SCLC. 60% of the patients with SCLC and poor PS who were treated with attenuated chemotherapy developed severe acute toxicities, as compared to 89% of the patients who were treated with upfront standard doses of chemotherapy. Those patients initially who were treated with attenuated doses and later who received full dose chemotherapy, severe toxicities was 69%. And there was no significant difference in the median OS of the patient who received initial attenuated doses chemotherapy than those who were started upfront full dose chemotherapy. Thus, stepwise approach of administering attenuated doses of chemotherapy to debulk the tumor, decrease tumor-related symptoms, and improve the PS, followed by full dose systemic therapy when PS has improved, may lower the toxicity of therapy. Coming to SVCO. So most common malignant cause of SVCO is non-small cell lung cancer, accounting for 50% of all the cases of SVCO, followed by small cell lung cancer. And at upfront presentation in SCLC patient, SVCO can occur up to 10% of the patients. So this was a systemic review of SCLC patients with SVCO at presentation. So SVCO was present at diagnosis in 10% of the patients with small cell lung cancer, and 1.7% of the patient with NSCLC. In small cell lung cancer, chemotherapy and or radiotherapy relieved superior vena cava syndrome in 77% cases, as shown in this meta-analysis. Again, this was an prospective observational study of 724 patients of small cell lung cancer. Of those, 87 patients presented with small superior vena cava syndrome at the time of presentation. That was around 12% of the study population. And with standard doses of chemotherapy, median survival was not significantly different in both the subgroups who presented with superior vena cava obstruction or not. Coming to TLS prophylaxis regimens. So, small cell lung cancer comes into intermediate risk category where monitoring of TLS, adequate hydration, and TLS prophylaxis with allopurinol or febuxostat is advised. So, monitoring of TLS should be done 12 hourly, or it depends upon the disease burden, risk of TLS, and patient's condition, and as well as laboratory values. So, renal function tests, uric acid, calcium, phosphate, and intake output should be monitored. To conclude, in the absence of data from large randomized trials, data from the observational studies like ours provide valuable information. And chemotherapy definitely prolongs survival in patients with SCLC who are having poor PS at presentation. Stepwise approach in which initial attenuated doses of chemotherapy administered followed by full dose chemotherapy once PS has improved may lower the toxicity and improve the tolerability. Thank you.